So we'll study about mandibular fractures today. Okay, so this will start our division of craniomaxillar fixation and trauma. Okay, so first is mandibular fractures. In this, some of the fractures, yes, we can do it in our clinical practice also, and some of the fractures they require proper hospital setup. Okay, which can be taken under general anesthesia. So we'll cover this topic under the following heads like introduction and histological background, applied anatomy of the mandible, etiology, classification, clinical presentation, radiological examination, then treatment like closed reduction and open reduction, and conclusion. So a fracture may be defined as a sudden violent solution of continuity of bone and may be complete or incomplete in character. In the earliest description, it was given by Egyptian literature in 1650, then considered to be uncurable, and the treatment options were not there, so which led to the demise of the patients. Hippocrates in 350 BC revolutionized the concept of management of the mandibular fracture by reapproximation and immobilization. In 1180, this textbook is written in Italy describing the importance of the establishment of the proper occlusion. And in 1942, an edition of the book Research printed in the France mentioned the use of maxillomandibular fixation for the very first time. Even in 1795, Copat and Dussault described the effectiveness of the elevator and depressor muscles on the mandibular fragment. Thomas Bernard Gunning, the Gunning splint is very common, so was the first one to vulcanite a use of the fitting splint to immobilize the fractured mandible, mandibular fragments. He used double arms extraorally to encourage the head cap and soft rubber chin support. As you can see in this figure, this soft, and this is connected with this head cap. So after that, the concept of occlusion was introduced, and by the concept of occlusion, then various type of fractures of mandible, they are then they tried to reduce them into the occlusion so that their accuracy can be maintained. The Thomas principle presented a technique of intraoral open reduction, which was with silver wire osteosynthesis, and spiral spring-like termination was tightened intermittently until reunion was secured. So this was the spiral, this was intermittently tightened so that the fracture reduction was there. In 1915, IV attempted the use of Sherman's steel plates but abandoned the method because of infection and necrosis. In 1917, Cole used silver plates and screws on each side of the fracture. Then this is the history of maxillomandibular fixation. The Gilmer wiring, Thomas Gilmer in 1849 to 1931 taken full advantage of the dentition for the treatment of mandibular and revitalized the MMF. Gordon Buck was first to place intraosseous wire in the mandible fracture. Then Major in 1938 intermedullary pinning, and Kristanen in 1945 introduced the tantalum plates for the interfragmentary stability and unstable fracture of the mandible. See, most of these fracture and this innovations that was done in the period of World War I, II, like that. So Robinson and Yoon in 1963, they have used L-shaped plate. Then Hans Luhre in 1968, they use Vitalium mandibular compression plate. Bronze and Boring in 1970 introduced lag screw. Spissel in 1972, gap results in the alveolar region or the zone of tension. Then Champy, we used Champy's principle for the plating for tension band principle, and Millet would use non-compressible bone plates. The epidemiology states that the males are greatly affected than the females because of the this fight and all, and so the age is between 16 to 30. Yes, young patients are more there. Then RTA, road traffic accident, assaults, falls, sports injuries, most common cause of the mandibular fractures. Then site of weakness is the third molar region, okay, especially when the tooth is impacted. So during the impaction procedure also, you have to take care so that you might fracture the mandible while using judicious forces. So unjudicious forces. So be judicious, be the judge of your own patient, and apply minimal pressure, minimal trauma to the investing tissue so that the tooth comes out easily. Then socket of canine tooth, yes, canine, and then these are the most common areas. Then condylar neck, these are the common areas of mandibular fracture. As you can see in this diagram, so dentoalveolar fracture 3.1 cases percent, coronoid 1.3, this ramus 1.7. Yes, this one, this area and this area, they are the biggest one. And then the canine junction and parasympathetic fracture 22%. Okay. So epidemiology, a study on the pattern of the incidence of the mandibular fractures. So this study was undertaken to the study of mandibular fractures clinico-radiographically and aimed to calculate the incidence and study pattern and commonest site of the fracture for the population around the Lucknow. This region in the India called as Lucknow. The patient presenting the history of trauma and in and around the city of Lucknow was recorded in this study. So this was the, according to the study, was the incidence. Okay. In this part, according to this, parasympathesis, body, and subcondyle, these three regions are highlighted. So these are the conclusion of the study that which fractures are common in which age groups, and the commonest combination was parasympathesis with subcondyle followed by body and angle. The applied anatomy, mandible is the largest and strongest facial bone. The mandibular fractures occur twice as often as mid-facial fractures. Okay, and experiments on the cadaver shows that almost all the 4 times of such as forces required to the fracture of the mandible than maxilla. So this is the applied anatomy of the mandible, the parts of the mandible, the body, then mental foramina, base of mandible, angle, ramus, mandibular foramina, neck, head, condylar process, notch, and alveolar crest. Mandibular fractures are classified as, if you classify anatomically the mandibular fractures, then they are classified like the parts of the mandible and the fracture of the mandible. Condyle, condylar fracture. Coronoid, coronidal fracture. Ramus, ramus fracture. Angle, angle fracture. Body, body fractures. Parasymphysis, symphysis, consequent fractures. Okay. Then in Luque and Hodgson in 1967, they showed that the isolated mandible is liable to particular patterns of the distribution of tensile strength when forces are applied on to it. The muscle attachments and displacement of fractures, the periosteum is the most important in determining the stability of the fracture. Gross displacement cannot occur if it remains attached to the bone. Once it is removed, the displacement of the bone end is free to occur under the influence of the attached muscles. The fracture at the angle, vertically favorable fractures and then vertically unfavorable fractures. Why they are unfavorable? Because of the pull of the muscle. See, when the fracture is like this, okay, this muscle is pulling this segment behind. So ultimately this muscle is uniting this fracture or reducing this fracture. So it is vertically favorable fracture. Now in this case, the fracture line is opposite to that. Okay, this muscle is pulling the fracture fragment away from the rest of the fragment. So it is vertically unfavorable fracture. Same as horizontally favorable and unfavorable. If the fracture is like this, so the muscle is pulling this segment upwards towards this fracture line. So it is horizontally favorable fracture. And if it is like this and it is pulling away, then it is unfavorable. So minimal displacement occurs when the fracture line passes between genial tubercles. Fracture lateral to the midline of the fragment with genial tubercle is displaced lingually by the pull of genoid and mylohyoid muscles. So biomechanics of the mandible is a class 3 liver with the condyle being the fulcrum. The muscles of the mastication acting as applied force, biting force act as a resistance. So you can see the class 3 liver principle. Fulcrum is here, and the condyle, applied muscle force and resistance. Just opposite to that, like this. Okay, can you see this? This is the fulcrum, this is the effort arm, and this is the loading arm. Like this. So the forces are crossing each other. Okay. So when loaded, the mandible exhibit maximum tension at the superior border and the maximum compression at the inferior border. This is a gradient between the zones of tension and compression. Lies a neutral zone, which is opposite forces is total 0. In this model, it would be mechanically advantageous to apply rigidity. The fixation hardware along with the zone of tension to superior border. So the classifications are according to the type of fracture. General classification: simple, compound, comminuted, complicated, impacted, green stick, and pathological fracture. This is the general classification of the fracture that applies to any fracture in the body. Then simple with no communication with the exterior interior. The compound is communication through the skin externally through the mucosa or PDL. Then comminuted fracture, they crush multiple pieces. Violent forces are the main culprits. Then high velocity farm missiles like this. And complex fracture, they are damage to the vital structures as well. So they are very complicated. So this is the example of comminuted fractures and complicated one also. Then impacted fractures, they are very rare. One fragment is driven firmly into the other. They override or impact in each other. Okay, override or impact in each other. Clinical movement is not appreciable in those type of fractures. Then green stick fracture, one cortex is broken and other is bent. It is an incomplete fracture. See, if there are two cortexes, one cortex is broken and other is bent. So it is an incomplete fracture. The fracture is not complete. Okay. And pathological fractures, generalized skeletal disease, localized skeletal disease, both can be there. In generalized osteoporosis, Paget's and osteomalacia is there, and localized skeletal disease, osteomyelitis, cyst, or osteoradionecrosis is there. That leads to the pathological fractures. Now the classification of the mandibular fractures according to the anatomical locations, like Rose and Keeley classification. Fractures not involving the basal bone called as dentoalveolar fracture, and fracture involving the basal bone are the other one. So in this, unilateral, single unilateral, double unilateral, then bilateral, multiple fractures. And in Digmund's and Netwick's classification, the mandibular fracture, coronoid, condyle, ramus, angle, body, symphysis, alveolus. These are the various according to the parts. Then causes of fracture: direct fractures, indirect fractures. Direct fracture means if the injury is direct, the fracture is here only, and indirect fracture is the injury is there. Here it is a fracture or not, but due to this connection of the mandible, the fracture on the opposite side is indirect. As you can see in the figure also, the injury, the impact is here on the parasymphysis region, but the fracture is of angle and condyle. Okay. So completeness of fracture line, complete fracture and incomplete fracture. As we have already discussed about green stick fracture, that one cortex is fracture and other is bent. The number of fragments, single, multiple, or comminuted fractures. And according to direction of the fracture line, horizontal favorable and unfavorable fractures, vertical favorable and unfavorable fractures. So the presence or absence of the serviceable tooth in relation to the line of fracture Class 1, teeth are present, but both teeth are off on the sides of fracture line. Then teeth are present only on one side of fracture line. And class 3, the patient is edentulous. This is class 1 fracture. Teeth are present on the both side of the fracture line. Class 2, present only on the one side of the fracture line. And class 3, the patient is edentulous. In clinical examination, a thorough study is imperative for the proper diagnosis and mandibular fracture. The extraorally swelling, ecchymosis, associated soft tissue lacerations, facial symmetry, and obvious deformity of the bony contour, hemorrhage, blood stains, saliva, and dribbling from the mouth. Change in the occlusion, anterior open bite can be there, posterior open bite can be there, unilateral open bite or posterior cross bite. Anesthesia, paresthesia, or dysesthesia of the lower lip. Abnormal mandibular movements, deviation of the mandible on the opening of mouth. Laceration, hematoma, and ecchymosis. Ecchymosis or hematoma in lingual sulcus is the diagnostic sign of mandibular body or symphyseal fracture. Can you see this ecchymosis here? It is also called as sublingual hematoma or Coleman sign. Okay, this is a very famous sign, Coleman sign. So the change in the facial contour and mandibular arch form, flattening appearance of the lateral aspect of face, deficient angle of the mandible, retruded chin, and elongated face. Loose teeth and crepitation on palpation, tenderness, step deformities, mobility of the fracture segment is palpated. The mandible should be grasped on each side of the suspected fracture gently and manipulated to assess the mobility. So it is called as bimanual palpation. Bimanual palpation. Then in radiological examination, yes, we have all type of facilities available nowadays, but the first of the basic facility is panoramic radiograph, then lateral oblique, posterior angle, occlusal view. Sometimes we need for the some antibiotics for the sinuses also, and reverse Townes view like computed tomography and 3D CT scan with reconstruction. So this is OPG. Again, reverse Towne. AP scans. Okay, in scans, you can very well appreciate the hematoma in the sinus also. This is a zygomatic fracture, maxillary wall fracture, like that. And this is 3D reconstruction. This is 3D reconstruction. As you can see, the overriding of the condyle hair and coronal fracture. Both are fractures. Okay. The treatment, the principles like general physical state should be thoroughly evaluated. Almost never ingrained. Then dental injuries should be treated concurrently. Establishment of the occlusion is the primary goal. Fracture teeth may be jeopardized for the occlusion. Then mandibular cuspids are the cornerstones of the treatment. Prophylactic antibiotics should be given with multiple facial fractures. Mandibular fractures are treated first. So two types of treatment are close reduction and open reduction. In close reduction, the indications are glossary comminuted fractures, non-displaced unfavorable fractures, then non-displaced favorable fractures, most of the edentulous mandibular fractures, then fracture exposed by significant loss of overlying soft tissues, most of the mandibular fractures in children with developing dentition, the coronoid process of the fracture, most of the condylar fractures. In close reduction, the contraindications are severe asthma patients. Yes, you can't give close reduction for the asthma patients. For the seizure patient, gastrointestinal disorders, like the patient is having nausea, and then psychiatric or neurological problems, and patient with pulmonary disease. And in close reduction, advantages are it is a very simple technique. The treatment may be carried out in the outpatient department only. The disadvantage of patient monitoring is required, and chronic contraindications are chronic airway diseases. In close reduction, direct and indirect skeletal fixation, the treatment modalities are bandages. Yes, this is the first line of treatment. Then bridle wire, then direct interdental wiring, indirect interdental wiring, continuous loop wiring, arch bars, maxillomandibular fixation screws, cap splints, gunning splints, and pin fixations. These are the types. This is bandage. So we have Barton bandage or barrel bandage for that. This is simple bridle wire. Loop of wire is given interdentally so that it can reduce the fracture or stabilize the fracture. Then direct interdental wiring, simple rapid method of immobilization like this. This is also called as Gilmore wiring also. Okay. So we prepare loops in separate teeth. Okay. Like 6 in mandible and 6 in maxilla. And then we tie them in crisscross fashion so that it is the maxillomandibular fixation should be there. Keep the mandible in occlusion and then tie the loops. This is a very simple technique called as Gilmore wiring. The next is IV loop wiring. In IV loop wiring, we prepare IV loops and then we tie them with each other. Like this. Preparation of IV loop. First, prepare a loop, put it in the, then from one side, take one out, other side, take another out. See, both are out. Then the distal one is passed through the loop and attached with the mesial one and tied up. So drawbacks of eyelet wiring: eyelet drawn into the interdental spaces, elastic traction is used during eyelet and it is a time consuming process. Then button wiring is there. So titanium button with 8 millimeter of diameter with 1 millimeter rim and 2 millimeter deep, 2 mm diameter with 1 millimeter holes apart. So it is passed. This button will stop the wire and the wire is pulled outside and then tied up. Drawbacks of button wiring: contraindicated in severe crossbite cases and anterior open overbite and difficult to apply in a single tooth. Now continuous and multiple loop wiring. This is also called as stout wiring or Colonel Stout wiring. He was an army person in 1943 during the World War. He discovered this wiring. So it permits the block of teeth in jaw to be wired. Elastic traction is used to reduce the fracture. So it is a fast wiring process. So prepare an big IV loop. It is put like this and the wire is taken out like this. Then this wire is taken out like this and it is wired again and then put again back, then from the another teeth, then put again, then another teeth and put again. So main wiring is done by the internal one. It will come out, make a loop on the outside wire and then go inside again. Then again come out, make a loop and go again like this. So ultimately the internal wire is moved like this. Then these loops are winded up and these loops are then connected with the upper section, okay, or the maxilla. Then arch bars, we are pre-casted arch bar for the greater accuracy of the occlusal reduction. So they can become much custom made also. These are the various type of arch bar. Mostly we use C arch bar. So indication of C arch bar is also known as Eric arch bar. Eric arch bar. So indication of arch bar: simple dentoalveolar fractures. Yes, it unite the dentoalveolar fractures are insufficient. They splint the teeth also. Okay, the insufficient teeth for eyelet. If there are insufficient teeth for eyelet, then multiple tooth bearing fragments required reduction. integral part of internal skeletal suspension and used for fixation of the subluxation of the tooth also. Advantages of arch bar: easy to apply, reduce operating time. Key points: proper length, malleable, it is using the orthodontic tooth movement also. Then the interdental wiring of 24 to 26 gauge can be used. It is passed and secured below the height of the contour of the permanent teeth to avoid piercing of the gingiva if possible. Okay, hook on the arch bars to place towards the gingiva, pre-stretch wire. Okay, twist the wires in clockwise direction and apply forces apically when tightening the wires. Then secure the arch bar in premolar region on the one side, then work on the around the other side. Hold the wire below cingulum and lingual of the anterior teeth. Lightly tightening all the wires, then do final light tightening after cutting wire short. So step by step, first pass a wire, okay, then place a arch bar here and tie the wire, okay, and continue with the all the teeth. Then when these teeth are secure, the arch bar is secure, then put separate wires and do cross arch wiring. This is the cross arch wiring. So first arch bars are secured, okay, and then cross bar wiring is done. The length of fixation of fractures in children usually unite in 2 to 3 weeks. For adults, 6 weeks, 1 month, 1.5 months. Okay, 6 weeks. Older patients, 1.5 to 2 months. The disadvantage are overextended arch bar may impinge on the buccal mucosa. Tails of the protruding dental wires impinge on the mucosa of the tip. Interdental wires become loose and ineffective because of the poor placement. MFF is ineffective if too few teeth are secure. So next is residence wiring. In residence wiring, wire is passed like this on the both side, okay, and then small this overlapping is done. They are pulled like this and secured with other wires. So this is resident wire. Now MMF using screws. This is the most easiest method. You put mild anesthesia here. These are just like mini implants you have used in orthodontics also. Okay, so we have a separate orthodontic mini implant course of 1 day. Okay, so these are the screws are just like mini implants. Self-tapping cortical screws are placed in the alveolus between two roots, one screw in each quadrant like this. Okay, these screws are 8 to 14 millimeters of the length. The rapid method can be done under local anesthesia. So wire can be passed from here to here and here to here so that occlusion can be achieved. Can you see this? Now then next is gunning splitting, the indication for the reduction and fixation and immobilization of the unilateral, bilateral or edentulous mandible. Okay. Contraindication, unfavorably placed fractures and grossly comminuted soft tissue bone loss. So these splints are made. These splints are made. These are placed on the upper and lower of the mandible. This is the hole in between for the food and all. And these are placed with the help of wires. So gunning splints can be placed under general anesthesia with soft gutta percha, registered impression of the alveolar edge in reduced position. Then pre-alveolar wiring is there, circumferential wiring is there, then jaw is immobilized. So this is the placement of the gunning splint. So it is wired with the mandible and maxilla. Pin fixation advantages: controlled fracture of the fracture fragments, avoid surgery at fracture site, retain periosteal blood supply, simultaneous treatment of middle and third mandibular fracture. And disadvantages are they are very uncomfortable, universal joints required tightening, difficulty with washing, shaving, and soft tissue scarring is there. Indications: pathological fractures, gunshot injuries, and osteomyelitis in a dentulous fracture site, fracture with extreme atrophy of a dentulous jaw, and gross communication of the symphysis of the mandible in edentulous patients. These are the various types of pins. They are used in the cortical. One cortex is involved. Okay. Extraoral and basis scar. So next we are discussing about the so we are now having this mandible in front, and how to give the next this. We have after mandibular fractures, we have lipid fractures or the maxilla, and our mandibular plating is left in the previous part. So the plating part we'll discuss in this, because plating requires the open reduction. Okay. So this is LEFO 2 fracture. This was LEFO 1 fracture. LEFO 1 fracture is the fracture of maxilla only. LEFO 2 fracture, it involves the nasal bone also. Okay. And in LEFO 3, it is involving the posterior orbit also. Okay. So these are the muscles of facial region. Then we have in maxillofacial region, we have fracture ZMC, zygomatic complex fracture. Okay. As you can see, this is typical panda eyes, or you have seen the panda beard. This is panda eyes. Depression of the zygomatic arch. Comminuted area. Soft tissue injuries. So this we have already seen the support bandage, button bandage. These are the extraoral. These all were historically previously used. Various types of wirings. Splints. Medullary pins. Gunning splints. And then comes the stainless steel plating. Now, whatever be the fracture, if we are going for open reduction, okay, so plating is done. Now this you can see a classical LEFO 3 fracture with a frontozygomatic suture fracture. So this is a frontal bone and zygomatic area. This is the fracture line, frontozygomatic suture area. So mini plates or titanium plates are screwed here on the 2-point fixation and here 2-point fixation. So these are 2-point fixation plates, 2-point fixation plates. Here you can see intraorally in the some maxillary area here, okay, or zygomatic buttress area, the fracture is reduced. So this is how LEFO 1 fracture can be treated, and LEFO 2, LEFO 3 fracture with the frontozygomatic. And can you see this infraorbital plate? So this is the stabilization of the fracture. Then in mandible, Chamfy's principle are used. Chamfy principle states that in the parasymphyseal region, we have to put 2 plates because of the lower of the fracture line tension areas, and posteriorly superior border plating. So this is the parasymphyseal area. Open the area, and can be done under local anesthesia also, but mostly general anesthesia is preferred for plating because of for the cooperation of the patient. If the patient is moving, your plates can be disrupted. Now, after that, there are 3D plates. 3D plates means there is 3-point fixation here, 3-point fixation here, and it gives a multiplication. See, these plates are interconnected, so the distance between the plates is regardless, it is calculated. So it will give the 6-point fixation effect. Okay, and this will give a 4-point fixation effect. So these are 3D plates. They're very popular nowadays. Then these are micro plates, very small plates with meaning screws type. Then there are bioresorbable plates. See these plates, these are of bioresorbable material. These are latest and it is made up of polydioxanone or polyglycolic acid, polylactic acid. It some contains antibiotic and bone morphological proteins also. Advantages is no second operation and can be left in the body forever. And highly biocompatible. Disadvantage, long lasting resorption time is long lasting and they are very costly. Biocortical screws, they engage both of the cortexes, both of the cortices. Then self-tapping screws used for IMF. So after IMF, after 6 weeks, when you have removed the rigid wires, you can keep the screws inside, okay, and put guiding elastics Then these are recon plates, sometimes used in the cases of pathological fractures or resections also. Recon plate, it's a long plate with number of holes. So we give, when we give order to the dealer, we can give 30 hole plate or a 24 hole plate like this. This is a mandible reconstruction. So fragmental fracture, so that one plate is going and fixing everything. Very strong plates, you have to bend it outside the mouth. Okay. And for the fracture thing, if we are getting a nasal intubation sometimes, and sometimes when both maxilla and mandible are involved, we have to go with the submental intubation. So in submental intubation, yes, from below the mandible, you have to keep this like, and then the tube is passed from here to here. So this is submental intubation. So various type of diagnostic images we have already discussed. In maxillofacial region, there are some regions for aesthetic incisions like in the hairline, okay, or in the wrinkles or creases. So there are brows incision. Brows incision is incision at the superior border of the lateral brow like this, and plating is done. So frontozygomatic or FZ region is visualized and plated. Then the lower eyelid approach. See here you can see the sum of the wrinkles. So and you can palpate the lower border also. So lower orbital rim of orbital floor, it is passed parallel to the ciliary margin, just caudal to the torus. Orbicularis muscle is dissected. Then skin muscle flap is turned down, orbital septum to expose the infraorbital rim. Incision on the facial side of the rim above the interorbital nerve is given, and then suture back. Transconjunctival lateral approaches through the canthus, It is not then on the skin, it is through the canthus. May require more practice to this. So orbital 4 and lateral orbital wall and infraorbital rim. The lateral orbital rim is 1 centimeter of the after suture is inside. Then there is bicornal approach or cornal approach for the maxillary fractures. This is called as hemicornal incision also. Then bone grafting, yes, sometimes if we have open area, we can use a Calvarian bone graft from this area also. In short, modern trends in oral maxillofacial trauma are open reduction with the help of concealed and aesthetic incisions. Then newer biocompatible materials are used in advanced material. Rigid fixation is using these materials. So if the patient can afford this type of treatment or can go for the advanced treatment, yes, you can definitely, you should apply advanced treatment or advanced approaches to the this to rehabilitate the patient. If possible, if you can use a biocompatible, bioresorbable plates, then that is the best for the patient. Otherwise, simple plating can also heal the fracture. Sometimes titanium plates, you have to take them out. Otherwise, there is no requirement to take them out. And as far as possible, in your clinical practice, go for close reductions, not for the open reduction. Open reduction required more support and medical support also. Okay, yes, for mandible and all, because the patient in local anesthesia, while reducing an open fracture, he will be very uncomfortable. Okay. So with time and prognosis have improved, and our conclusion is, despite our improvement, we still have a long way to go. Correct. So this will our this craniofacial trauma and maxillofacial trauma. The insight is there in oral surgery. Okay.